Good afternoon, folks. We're going to give just a few seconds here for people to jump on because once you open up a Zoom webinar, it does take a while for folks to end up jumping on the screen altogether. And those of us on this side can see the numbers go up. So we'll give just a minute here. Glad that you could join us on this very chilly New Hampshire afternoon. Okay, we're going to go ahead and get started. Welcome. I'm Michelle Wagner, and I'm with NAMI New Hampshire working on the first episode Psychosis Early Serious Mental Illness Initiative. Thank you for joining us for today's webinar, New Hampshire Rapid Response Access Point, a new system for navigating mental health crises. Today's presentation is being recorded, and you'll be able to find it on the Onward NH website, so on the education page of onwardnh.org. Though we aren't offering formal CEUs for today's presentation, we will be providing a certificate of attendance, and that will come out when you do the survey afterwards. This is a Zoom webinar, so your camera and microphone are off. The chat is also turned off. Instead, we ask you to enter any questions you have in the Q&A feature. Emily Huff with NAMI New Hampshire is helping with tech support behind the scenes. So together we'll work to answer as many of the questions that you no doubt have as we can. Certainly at the end of the presentation, we'll have lots of time for Q&A. So joining us today, we have two members of the team from Beacon Health Options, Eric Eason and Dr. Jeffrey Height. Eric is a licensed professional counselor who's worked in the mental health field for nearly 25 years, and Jeff is a licensed psychologist with 20 years experience in crisis services and community mental health. So Eric and Jeff, we welcome you both, and I'm going to turn it over to you.
Thanks, Michelle. Good afternoon, everyone. My name is Eric Eason, and as mentioned, I am a licensed professional counselor. I currently hold licensure in the state of Georgia, and for my whole life, I have lived in Georgia, but I am recently relocated to New Hampshire so that I can be a part of the community here in New Hampshire that we're actually serving. I've worked in crisis services in Georgia for the past 7 to 8 years. I helped operate a crisis call center as well as mobile crisis teams. Our mobile crisis teams covered about 110 counties around the state of Georgia. We had about 275 folks working on that team to see people in crisis. So I'm very familiar with what mobile crisis work looks like and how a contact center works, call center works. So I was happy to join the Beacon team here and help get this initiative moving and rolling and working for the folks of New Hampshire. Also enjoying very cold weather here. It's quite the adjustment, but so far so good. I'm looking forward to that foot of snow we're anticipating this weekend. Jeff?
Well, I have to say, tagging off of that, I'm happy to be on the West Coast. It is actually quite cold here today, so I'm wearing a sweater. And by quite cold, I mean just roughly 35 degrees. So there's a small chance of frost where I'm at. To provide a little bit more of an introduction, as Michelle mentioned, my name is Jeff Height. I am a licensed psychologist. My practice or my work is based out of Washington. I've been with Beacon Health Options for about 5 years now, and am a clinical program director with our Rapid Response Access Points. Just a bit more about my background. I've worked in crisis services for about 20 years now, overseeing crisis line operations, mobile crisis teams, and designated crisis responder teams here in Washington, which would be the equivalent of an IEA team there in New Hampshire. So for the last 6 months or so, I've been a part of the Beacon National Crisis Product Team and have been working pretty directly on the implementation for this Rapid Response Access Point program in New Hampshire. So very excited, not only for the work that we're doing in New Hampshire, but what we'll be doing over the next couple of years to continue improving our crisis system of care. So again, very, very excited. So I'm going to start us off today with a little bit of a general Beacon Health Options overview, and then we'll get a little bit more into the specifics of our work in New Hampshire. So moving to the next slide, Beacon operates as a behavioral health organization with 35 years experience in offering behavioral health services. We cover approximately 44 million lives across the country and have nearly 25 years experience developing crisis systems of care. So to highlight a couple of the bullet points there on the right, the second one, we have a long history of providing program oversight and consultation for Medicaid and governmental agencies. The next point, which is specifically relevant to the work we're talking about here, is we have expertise in developing and implementing customized crisis response systems for states and counties across the country. And then maybe skipping to that last bullet point, we have proven outcomes in engaging diverse stakeholder groups in purposeful, action-oriented collaboratives. And we're going to be speaking a little bit more about that here in a few minutes, but we are very excited as we get going a little more fully in New Hampshire to be starting that process of engaging the community in conducting crisis collaboratives on an ongoing basis. So we'll talk a little bit more about that in a minute. Speaking about our crisis capabilities, starting with the box there that you can see on the left, we will be operating a crisis contact center, or the rapid response access point. That access point will include a number of different types of staffing, including the crisis counselors, licensed clinicians, and peer support specialists. And we'll be doing everything from taking in that call, that person in distress or that family in distress who might be calling. We'll be answering those calls, trying to provide engagement and support to the individual who's calling in, assessing for any potential risk, and then determining the best next course of action in terms of providing services. And that might include an array of services, including providing referrals, connecting with outpatient or ongoing services when appropriate and possible, and then when necessary, dispatching the rapid response teams into the community to provide further crisis assessment. One of the ways that we're doing that, or one of the ways that we support that process, is through strong air traffic control. So in New Hampshire, we'll be utilizing a closed loop referral system that allows us, that's a GPS enabled system that allows us to identify the location of the person who might be calling in crisis, and then visually see where the next closest rapid response team is located based on a GPS map. That allows us to respond as quickly as possible, and we have hopes of being able to respond to all crisis situations in communities within an hour across the state. Jumping to the bottom right-hand corner, as a part of this process, we'll be collecting considerable data, whether it's through the access points or data as a part of the interventions in community. So we'll want to use that data as a part of a data-driven decision-making process to ensure that over time we are analyzing the crisis system of care, how we're doing, how well we're providing services, and where there might be areas where we can continue to improve. Speaking just for a second on that top right-hand corner about stakeholder engagement, I think I've already mentioned this one time, but pretty quickly we'll be initiating crisis collaboratives throughout the state, and that'll be a process of regularly bringing community stakeholders, crisis expertise, and other interested parties together to look at the crisis system on a regular, ongoing basis, analyze the work that we're doing, and then hopefully over time improve to the point where we're providing excellent crisis services across the state. Next slide. Speaking a little bit about Beacon's crisis footprint, up there in that blue banner, in a number of states, including Idaho and Delaware, we are already offering crisis consulting to stakeholders, including government officials, community agencies, and other interested parties. In Massachusetts, since 1996, we've been operating the Emergency Services Program that includes crisis assessment, intervention, and stabilization services. And we offer a web-based search tool for behavioral health providers, emergency departments, and other stakeholders. In Georgia, we've been operating since 2015, managing the crisis hotline, dispatching the mobile crisis teams, capturing and tracking critical information, and refer to needed care and traffic services when necessary, or track services when necessary. I think Eric, with his experience in Georgia, can speak a little bit more to that. In addition to that, we've been conducting quality reviews for the crisis stabilization units. And the next slide. In Washington State, where I'm from, we've been operating as the administrative service organization since 2016 for 8 counties. And that covers, in Washington, we cover all individuals, regardless of insurance coverage, through a braided funding mechanism. And as the administrative service organization, we contract and oversee the mobile crisis teams, the designated crisis responders, or those who conduct IEAs, the process familiar to you in New Hampshire. And then we have a 24/7 hotline service. Very recently, effective in just October of this year, we began operating in Kansas, the statewide hotline for youth, And that includes both operation of the crisis line through the access point and then mobile dispatch when necessary. And then you'll see on the bottom right-hand corner, our work just beginning in New Hampshire. So effective just this month, January 1, we're offering the statewide hotline for all ages, and that includes mobile crisis dispatch. I've already spoken about the closed loop referral system or the air traffic control. And then we'll be, in addition to that, we've been training and preparing the mobile crisis teams for dispatching community. And then as I've also mentioned, we'll be spearheading the community collaboratives across 10 regions throughout the state. Next slide. And just to speak a little bit about some of the outcomes we've seen. And so things we're hoping to expect to see as well in New Hampshire. In Georgia, upwards of 75% of calls by individuals are resolved during the course of that crisis call. Only 2% of calls result in emergency intervention. That would be thinking about lights and sirens or ambulance or law enforcement. And then approximately 80% of mobile crisis dispatches are resolved in the home without the need for higher level of intervention. And pretty similarly in Washington, we operate the 24/7 access line, and we see that 78% of issues are resolved over the phone, and roughly 90% of mobile crisis interventions are diverted from ED or higher levels of care. And then in addition to that, we see that 82% of those who receive services get follow-up within 7 days or less. Next slide, and I'll turn it over to Eric.
Sure. So these numbers really do paint a picture of how effective crisis services can be when done right. You'll notice that the very low rates of having to involve law enforcement, the low rates of having to hospitalize folks, and the high success rates, particularly that mobile crisis interventions tend to have at allowing people to de-escalate, remain in their homes, and utilize existing community supports instead of having to go into a hospital system. Ultimately, that's one of the primary goals for this system, is to reduce the need for hospitalization, reduce the need for law enforcement or EMS involvement, reduce the need for ER involvement. We're trying to create pathways that allow direct connection to community resources such as the CMHCs and other community supports that people can use and remain in their homes whenever possible. So you've been told this before, but just to sum up a little bit about what we're doing in New Hampshire, we are now operating a 24/7 crisis line, and this crisis line is able to receive phone calls, texts, as well as chats from the public. So you can access us any of those ways that you feel comfortable doing so. And we've got people available 24/7 to address your needs and to help you figure out what kind of help is available. You can call for yourself, for a family member or friend, or even if you're a professional, for someone who might be in your care that you're concerned about. We again aim to have linkage to local community-based resources. So again, the lowest level of care possible, trying to keep people in their home environment or at least in their community environment rather than having to be hospitalized somewhere else. We do dispatch rapid response teams, which are mobile teams able to go to your location, to your home, perhaps to a park or to a street corner where you happen to be. Pretty much the teams can go almost anywhere in the state to assist and intervene with someone who is in crisis. Those teams are available throughout the entire state. There are admittedly sometimes when staffing might require that response may occur virtually. I'm sure those of you living in New Hampshire can understand the need for that given inclement weather or certain other factors. But there is a rapid response mobile intervention available 24/7 around the state. And again, we are developing the closed loop referral system to allow appointments to be made with the local CMHCs. One of the services that we're offering is linkage to see someone at a CMHC if perhaps a mobile response is not appropriate or not desirable in a given situation, but someone really does need that de-escalation. We can offer linkage to be seen within the next 1 to 2 days at a local CMHC for some crisis intervention services to help folks de-escalate. This is a very busy slide, and this is one that's kind of easy to get lost. So I'm going to spend a fair amount of time trying to explain this to everyone. What we have is a flow that explains kind of how a call works. And the same would be true for calls, texts, or chats, understand, but I'm going to use the terminology call because that's what's kind of the default. That's also our largest volume is calls rather than texts or chats. So you'll notice we can accept contacts from a variety of people. Might be someone who's involved in state healthcare, local districts or schools, individuals who are calling for themselves, families and friends, law enforcement agencies, or other types of outreach teams or service organizations. So when someone calls in, the intake specialist who answers the call screens immediately for that risk criteria, right? Like obviously we need to establish who we're talking to and how to connect with you in case we get disconnected or need to reconnect. But then we're very quickly going to assess those risk factors. Questions around suicide, questions around other thoughts about, harming someone's self, or another person, perhaps any other sort of acute mental health or substance abuse symptoms that someone may be struggling with. We're trying to establish immediately or as close to immediately as possible the level of risk that someone is at for self-harm or for danger, so that we can determine what kind of response is appropriate. If we determine that this person's needs are what we classify as a mild or a moderate need, in other words, the risk to their life or the risk to their well-being is relatively low, then we're going to discuss possibly referring that individual to other supports that might be able to provide things such as, like 211 can support needs such as housing, food needs, clothing needs, those type of what we call social determinants of health needs that people sometimes need assistance with. We can also refer for services through our Open Beds platform to the CMHCs for people who, again, may not need immediate intervention, but who might need some sort of ongoing care. We also provide follow-up for those individuals who follow this pathway from a peer support specialist, someone who has lived experience in the mental health or substance abuse field and is living that experience. They can call back to do a follow-up with that caller within about 48 hours to make sure that that caller was connected to the appropriate service, that their needs are being met, and that they don't have any additional ongoing needs that they need assistance with. In the event that someone is presenting with a more serious concern, perhaps there is a risk and we're concerned about that person's safety, then if the call taker is a clinician, we'll jump right over to this column. If the call taker is perhaps not a clinician, then they're going to immediately involve a clinician in that call. And once the clinician is involved, then they're going to do an additional safety assessment to make certain that they understand the risk factors. So they're going to do a deeper dive into what are the thoughts that you're having, what are the behaviors that you're demonstrating, what are the things that put you at risk of self-harm, death, or other types of injury. And then once we've determined that need, we again will have to make a decision about whether this is something that might require immediate intervention, such as a 911 response. Perhaps someone has already done something to hurt themselves that might place their life at risk. In that case, it might be necessary to have medical intervention, so we might arrange for 911. Or perhaps the behavior is so risky that we really need someone on scene rather immediately to be able to intervene. Rapid response can take as much as an hour, and so if we're not confident that the person can maintain safety for that amount of time, we might resort to a 911 involvement. Now again, those pathways tend to represent a very small portion of the total number of calls that we're taking. So we're not calling 911 most of the time. It's a very small number. More often, we are able to determine that a person has enough immediate support and immediate ability to maintain safety that they're able to benefit from a rapid response mobile dispatch, at which point we use our Open Beds platform to identify the location of the person who needs services and identify the teams that are as close to that person as possible. Because again, we want to get the most timely response that we can. So we're looking for the closest team available to help that person. We will alert that team of what's going on. We send them a record of the information we've gathered on the phone so that the team is aware of why we're asking them to go and intervene. And at that point, the team then begins that communication with the individual to let them know, hey, this is Eric with the Mobile Crisis Team. I've been made aware that you need to see me. I'm on my way. I'll be there in about 45 minutes, and they'll begin that, they'll alert you and begin that process. Then, of course, when the team arrives on site, the intention, again, is to do everything that we can to keep you in your home and to access those community supports and community services that allow you to remain there without having to go to a hospital or some other higher level service. So obviously, the team is able to spend a fair amount of time on scene with you, maybe an hour, hour and a half, talking through what's going on, helping to identify what the needs are, helping to identify what resources you already have, such as family or friends who can support you, transportation resources, whatever, perhaps you are already involved in care. They can help to coordinate the support of all those people and develop an appropriate safety plan and an appropriate plan for care that allows you, again, to remain at home and access appropriate care moving forward. Of course, if they determine that that's simply not safe and that someone is in a situation where it's just not safe to allow them to stay at home, they're going to need to go to a more secure setting, then they can go through that process and they can look for an appropriate pathway to get someone into care. Ideally, future state, what we'd like to see is we'd like to see the ability to have direct admissions, but we're not there yet. The crisis system in New Hampshire is still building that capacity. So at present, people who require hospitalization are generally going to be referred through an emergency department, whether that be by the access point, the mobile team, or some other mechanism. But the long-term goal is ultimately to try and provide some kinds of pathways that reduce or eliminate the need for ER referral through that. So I don't want to give a false impression. We're not there yet, but we are aiming for that eventually. You can see a little screenshot of here of how we kind of are able to look at the map to see the location of a person and then to see the location of where the teams are near them. And that's how we're able to assign teams by proximity to respond as quickly as possible. These next two slides are very busy, and I'll be honest, you're going to get lost if you try to read the details. So let me give you a very high level overview. This just kind of gives you an understanding basically of how we classify the contacts that we receive, the calls, texts, and chats that come into us. You'll notice the scale goes from green to yellow to orange to red. And essentially, as you escalate in number and in severity, what you're looking at is increased risk, increased danger, those kinds of things. So for instance, at I would call the bottom end, even though it's at the top of the chart, at the bottom end of that criteria scale, you've got people who are able to be referred for outpatient services, community supports, those types of things, all the way up through mobile crisis, through more urgent referrals to services, through mobile crisis, up to the possible need for 911 or medical intervention. So that's kind of the way that we think about these things. Again, I don't want to get lost in the weeds here, but I do want you to kind of understand the concept that this is in large part a triaging process where we're trying to gauge risk and we're trying to level or understand the amount of risk to someone so that we can provide appropriate interventions when possible. And then again, not to muddy the water, there is an additional process wherein we assign a risk level for rapid response. So when we're sending a mobile team, you understand that there's kind of a wide range of needs that we might send a mobile team to respond to. And so we wanted to devise a way to allow the mobile teams to understand, kind of from their perspective, what the risk level is. And we're able to advise them that, this might be across the spectrum, 1 through a level 4 risk level. And you'll notice that at level 1, the lowest risk, this is someplace where the team is responding to a hospital, a jail, some sort of secured setting where you could probably send one person to respond because there are plenty of people around to support safety. Level 2 would be more of a community response where the team is responding without any additional support. It's just the 2 team members from Mobile Crisis responding alone. This is where we see the majority of our dispatches occurring. Level 3 does indicate the need for some sort of law enforcement involvement. But this is intended to be mobile crisis leading with the support of law enforcement in case there is some sort of aggression or some sort of self-injurious behavior, those types of risk factors that might present a larger risk or a greater risk. Then, of course, we've got the level 4, where this would be where mobile is responding with law enforcement, but law enforcement is taking the lead. This is someone who is much more acutely dangerous in that situation. Their behavior may be very aggressive. They may have likely or very likely intent to hurt or harm themselves or someone else. Or they may have been making overt threats or may have a weapon in their possession. So those are kind of the general overviews of our processes. And I know we've got quite a bit of time left. I see that the Q&A has started popping up on the screen.
It
So
sure has.
I'm going to let Michelle jump in a little bit here.
Yeah, thank you very much for that overview. That was terrific. And I believe Jeff was answering some of those questions as we went along. One of the first ones that we should address is the slides, because it appears that folks had some trouble reading the fine print. Are you going to make those slides available to us?
We can make these available. I don't see any reason why we can't. We can share those with NAMI, and NAMI, you can distribute those out.
Yes, and what we'll do is we will post these along with the recording, because folks did ask. Yes, it is being recorded, and it will be posted on the education page of onwardnh.org. That is the early psychosis, early serious mental illness resource. It's a website, has all of our prior webinars listed there as well on the education page. So you'll be able to find the recording and the slides there. And so questions are pouring in, a variety of them. You talked about a peer support specialist at some point in time. Mary is asking, are those people New Hampshire folks? Because I think hearing that Jeff is over in California, we're wondering where people are, who they are, where they're coming from.
And Jeff, you know more about the contact center operations than I do, but I can tell you that we do employ staff from across the country. So it is possible that some of those peer support folks may be from out of state. That's not to say that we're intentionally trying to avoid having folks from New Hampshire, but one of the things that we thought was important when we developed this process was we all understand there's a staffing shortage and a kind of a bit of a crisis, honestly, at finding qualified folks to do this kind of work. And so we wanted to allow the local teams, the local rapid response teams, to have access to all of the local resources. And we didn't want to be pulling from the same group of folks, right? We didn't want to negatively impact the ability of the rapid response teams to find folks to be able to respond in person. So we are employing people from around the country. I can't guarantee you that the person on the other end of the phone is going to be in New Hampshire, but what I can tell you is that we do have a small dedicated group of folks, and we've got a number of people who work call center operations, but we have a small group of folks to whom these New Hampshire calls are directed, who have gotten quite a bit of information and training specifically about New Hampshire and the processes in New Hampshire and kind of I'll say the culture in New Hampshire, the kind of general way that people think and think about things in New Hampshire. So we do have some folks who, even if they're not from New Hampshire, they've gotten somewhat familiar with what to expect from those calls. Jeff, I don't know if you have anything to add.
The one thing I would add is, in addition to what you've already described, each of the CMHC rapid response teams are working to employ peers as well. So between the peers that may or may not be from New Hampshire on the access point or the crisis line, there are also peers based in each of the rapid response teams. And so we will be coordinating pretty closely with those teams. And so you can expect, the hope is from a mission and a values perspective, we want to involve peers at every aspect of crisis intervention, from the access point to the response in community. And so we are expecting and hoping to have peers every step of the way.
Terrific. Peers are so important. They bring a vital component to a person's well-being. Elizabeth asks, are all these services free?
I can take the first stab at that. Yes, the intent is for all of these services to be free. That being said, There are instances where if you have a certain type of insurance, that insurance may be billed. The state also offers additional funds to help offset any costs. So there are certainly procedures in place through DHHS to try and offset any costs. But like, for example, we would not be billing directly. I mean, if you call the access point, we're not sending you a bill.
Thank you for that. Denise is asking about the phone number, and Kim Murdoch, who is our communications manager at NAMI New Hampshire, did put that in the chat previously. I do have a flyer with it on, and I'll bring that up at some point as we get close to the end. Can either of you just tell folks what that number is?
Let me pull it up to be sure that I'm telling it right. I'm still trying to memorize it.
I was doing the same
It
thing.
is-
I don't want to say it before I look at it.
So the number is 833-710-6477.
And texting,
You can text that same number.
so call or text to that number.
Yes, and if you want to chat, the website is NH, it's in New Hampshire, so nh988.com. And there's a chat tool on the website where you can initiate a chat.
So versus people who might get charges on a cell phone, because we do have folks who have limits on that. Is it free then to chat via the web through the website?
There's no cost associated directly with using that online service.
So that would be terrific for folks to use if they're concerned about finances.
And one thing that I would also tell you, and this is listed on the website, but you can do so anonymously if that's your preference. It does ask for things like name and email and phone number, because if you're willing to share that, we'd like to have that in case we're concerned and want to share help. But if you're really feeling like you want to do that anonymously, that is perfectly fine. You're certainly able to do so.
Great. And I do see a couple of people have raised their hands. We're doing a Q&A, so we will ask that folks please type their questions into the Q&A. That's how we're operating today's presentation. So for the TED asks, for the purpose of this service, please definitively define crisis as best you can.
So I will tell you the philosophy that I come from, and then Jeff, you let me know if my philosophy doesn't line up with with yours.
Well, we can compare philosophies. There we go.
There you go. All right. So the belief that we have, and I'm pretty sure that Jeff and I share this belief, is that I can't define what a crisis is for you. Ultimately, a crisis is self-defining. For instance, if my dog were to die today, I would be upset about that, certainly so. But I likely would be able to continue to function, to continue to work, to continue to pay my bills. But for some other person, that dog may be truly their whole world, and losing that dog could really completely crumble their ability to function in a moment. At which point they would really, need the support of additional resources and folks who could help. So we can't take one external factor and say, well, if this happens, that's a crisis, because the same thing could happen to two people and impact them very differently. So if you want me to try to define it in some theoretical term, the way that I've always defined a crisis is a situation that overwhelms the ability of a person to use their existing coping skills and their existing supports to be able to function at or near what they consider to be normal functioning for themselves. That's the way that I tend to define crisis.
Great.
I don't think I could add anything better than that. That was very well defined.
We appreciate that explanation. Thanks so much. Karen asks, if needed, should I call the Rapid Response Access Point, RRAP, instead of my Community Mental Health Center's emergency services number?
I'm glad you asked that question. So what we're doing right now is, because there has been a system in place for many years of crisis lines through the CMHCs, those numbers are now being routed to the New Hampshire Rapid Response Access Point. So you can call our 833 number, or you can call the local CMHC crisis line, and all of those calls are getting routed to the access point. We also, and I don't want to oversell or pre-sell a little bit, but I think that there's already quite a bit of knowledge around the advent of 988 coming in the summer. And so we're also going to use the same kind of approach when it comes time for that rollout, so that all of these numbers that we're putting out there will continue to operate, and as we gradually make that navigation to a new number, we'll monitor the usage of these old numbers and ensure that we're not cutting them off when people are still using them.
Excellent.
And the one thing I would add is, again, the intent of the access point is to operate as a crisis line, right? As we've just defined, as you would define. If you are looking to contact the CMHC to schedule an appointment because you missed an appointment, things of that nature, we don't necessarily want those calls coming into the access point because that is reserved for an individual who is experiencing a crisis. So if you are just needing to reschedule or for logistics, you would still contact the CMHC directly.
Thank you for those explanations. Something that was a question in the Q&A that has moved out of it, but I just want to make sure that it did get answered. If a person is connected with their local community mental health center, are you folks notifying the center that the person has called the access point?
So maybe I can start with that. So at the access point, we will ask, are you currently in services, and who are those services with? And if you identify that you're with the CMHC and then you give consent for information to be shared, we would send a notification or a follow-up email to let them know that you had a contact with the access point. If for some reason you did not share that information, or for some reason said, no, I'd rather that information not be shared, then we don't share that information. Oh, Michelle, I think you're on mute.
I am muted, aren't I? Talking away. So we were talking about peers previously. And so Ken asked a question, will those certified peer specialists eventually be trained in New Hampshire's peer support models and certified like all other programs? What's that going to look like for you folks?
So I think we are always looking to provide the best level of training we can in any situation. So right now, when we're hiring staff, we're looking for them to be fully qualified, trained in whatever whatever role. So if we are hiring peers, we look for those peers to potentially be certified as peers. If possible, yes, we would want them to participate in any sort of local training. Anything to enhance that local knowledge and experience is something we would be doing. I can't say for certain how that will sort out. But yes, we absolutely want our staff to be as fully qualified as possible.
I can also
hope that answers the question.
Well, and I can also add that the Department of Health and Human Services here in New Hampshire is intently interested in the kind of training that our staff has received. And there is a special discussion, or I should say a specific discussion going on around the training that our peers receive. So we can have that conversation with DHHS and find out what kind of specific training they might want our staff to engage in.
Okay, intentional peer support is used widely throughout New Hampshire, so I think you'll hear that as you go along. I'm skipping around a little bit on these questions. Barbara ended up coming in late, and I don't want to have to reiterate a lot of information, but it feeds into another question. She said she's a little lost. Can you reiterate how referrals to providers are made, to whom, and what additional burden this puts on existing CMHC wait lists? Because I think that last part is an important point.
So I'll start with the stab at this one. The state has provided funding specifically for the services that are associated with this crisis system. The appointments that we are referring to are not the same as the outpatient intake appointments for which there is a significant waiting list. The appointments that we're able to refer to are crisis intervention appointments. So they are not establishment of ongoing services. They are essentially just kind of a stopgap measure to provide that kind of crisis intervention. Essentially, think about the appointments that we're referring to as the same intervention you would get with mobile crisis, only it's happening at a CMHC location. So it's more of a crisis intervention well, it's more of a crisis intervention and not the intake that is, leading to ongoing services. So there are specific folks who are funded to just do this type of crisis intervention service that doesn't, it's not the same group of folks who are doing the other levels of care.
Jeff, anything to add?
No, again, very well described. So yes, of course, whenever possible, the access point is going to want to become very knowledgeable as a resource base. And so, we're going to be looking to provide the appropriate referral given the nature of the individual calling. So we hope to connect with the CMHCs. We hope to connect with other private agencies, other resource databases in New Hampshire. So over time, we hope to grow and become experts in the various resources. So I think that might touch on a couple of different questions that have been coming up. But specific to the rapid response follow-up appointments, those are specific to the crisis at hand.
Thank you. Going back to the phone number and how that information gets out there. Regina asks, are there materials for sharing on social media? I found a poster online, but so far, no other promotional materials. How do folks know you're out there? How do we know how to find you?
We do have some promotional materials. We've been partnering with DHHS to do the outreach primarily through the community mental health centers. That's been the avenue that they wanted us to take. Now, we do have some electronic materials that could be shared, and I can share those along with the PowerPoint so that everyone has a copy of that as well. There is a flyer, there's a brochure, and there's also a wallet card that can be printed off. And so the intention is that those things were distributed to the CMHCs to be professionally printed and then distributed, but anyone could print it. It would just be a not quite so professionally done copy of the information, but it's all the same information. So we can certainly get that out here. There have also been a number of newspaper articles as well, and we're trying to get the word out by, Jeff talked earlier about the community collaborative meetings. That's one huge way that we're really going to start getting the word out. We're hoping to start those meetings in late February, where we'll be meeting with all the community folks who were involved in services in each community, to be sure that people understand the service, how to access it, how to appropriately use it, those kind of things.
Jeff, Eric, we had talked earlier about folks being able to give feedback on the program, and there was a question in here that maybe was answered by a typed answer. What about that community collaborative? Can people in the community join in, or is that a set group that's already formed?
No, that will be for the community. So we would welcome, folks to join and provide feedback and input. And we'll be, again, those will be coordinated through the community mental health centers. So we will partner with each CMHC to help get the word out and promote those, so that people will know when they are. That would be an excellent place for folks to come if they have information to share about, if they called the access point and they got a particular experience, hopefully good, but good, bad, or ugly, we would want to hear about it. And so that would be an opportunity to connect with us so that we can then take that feedback and make any adjustments to the service necessary.
And when you're talking about the CMHCs, do not forget about NAMI New Hampshire, because
Oh, yes.
we have lots of folks we're connected with, and we're very happy to share information and invite people to those community events, and also to share the information. Kim Murdoch has been sure to be doing that on our social media and website.
I met with Kim and Susan yesterday and assured them I would be sure to include them.
Terrific. Thank you. Here's another plug. Don't forget, because we can really help with that. There were some other questions I wanted to jump around. There was one about psychosis that I was interested in getting to. This is my pet project, and that's what this series comes out of, is a first episode, psychosis. Katrin asks, will people who have psychosis or other distressing mental health problems be able to call this number to get support 24/7?
Yeah, absolutely. Absolutely. The intent is to provide that support, whether it be by phone only, or whether that leads to maybe a rapid response deployment and response in the community. But absolutely, this is a front door for accessing support and services.
And I would just put a plug in for the warm lines that we have around the state as well for folks to
Certainly.
call. So that's a good option for people who aren't actually in crisis but do need support. Audrey asked, and this goes back to talking about appointments. Will those appointments continue until the individual has an intake? So they connect with you, but they're not getting an intake at the community mental health center for a while. What's bridging the gap?
I don't know that that's something Jeff or I could really speak to directly, because that ultimately would be a conversation with the CMHC. We are essentially a linkage service, which means we're identifying the need and getting you to that service. But then that would need to be a conversation with the CMHC about what resources and supports are available for the interim. I'm not trying to deflect, but I can't answer that question assertively.
Right. Jeff, go ahead.
Well, I would add, I think the overall intent is to provide that bridge and that linkage. And so the hope is that yes, when we identify that someone's needing support and in crisis, we would want them to be served by that CMHC to the point where that crisis is resolved or reduced to the extent that they're okay until an intake is available.
Mallory asks, how would you address a crisis situation that requires emergency services for someone that has had trauma related to police interactions?
Well, trauma-informed care is a critical component of what we do. And for those who don't understand what that is, that's a lot of education and understanding of the variety of ways that simply contact with the mental health center or law enforcement can be traumatic to folks. So, we do train our staff in that trauma-informed care perspective. And we do encourage them to use trauma-informed care approaches. We also would be considering that, when making a decision about how to link someone to services. And again, I know the CMHCs, their staff are also trained in similar concepts and should be approaching with sensitivity. It does become a tricky situation, right? Because you're having to balance the risk of trauma to the individual and the goal to reduce or eliminate law enforcement involvement with the real risk of danger. So it's going to require a lot of communication between the responding team and the people who are involved with that individual to be certain that there can be a good level of safety and established to permit that encounter. But I would just say that that's really what it boils down to, is a lot of collaboration, communication, and cooperation between the responding team and the person and their support system to try and make sure that we're doing everything we can to reduce or eliminate that law enforcement involvement.
And I would remind people with us today that if they're calling for someone or calling for themselves, to give that information, to let folks know that there has been trauma around that in the past, because folks can't know unless they've been told that. Jeff, were you going to add?
Yeah, and speaking more to that end, again, as a part of the crisis collaboratives or the community collaboratives, we want law enforcement involved. We want to be participating in CIT training. We want to be bridging that gap so that much of what we're talking about extends out to law enforcement, so that when unavoidable, law enforcement approaches with a trauma-informed knowledge and understanding as well, so that we can look to really improve that interaction whenever possible.
That's an important point. And NAMI New Hampshire does CIT training. Sue Allen Samuel is a wonderful resource for that. And other organizations around the state also provide that very important program. Nina asks, what is the distance you could travel to bring someone to the hospital? We have folks up in the North Country who are forgotten. Are we taking care of them?
Yeah, the state is divided into catchment areas. So in the north area, Northern operates as the CMHC, and they have a rapid response team. So we are looking to deploy statewide. Based on our closed loop referral system, we are hoping to identify the closest team to the crisis and dispatch them so that the wait time is minimal. But yes, this service would cover the entire state.
Jennifer asks, one slide mentioned open beds, real-time available beds. Can you expand on this? I'm also curious about that.
So I want to be clear that, again, this is an area where the system is still growing and developing. This is not something that is fully developed at present. So I don't want to give the false impression that we suddenly have the capacity to open the system and suddenly know magically every bed in the state. But I will tell you that that capacity is a part of the OpenBed software. And that is something that we are building toward. So there is a time in the future when we hope that we will be able to use that software to quickly identify every available bed, directly from the community and hopefully provide direct linkage. So again, that's more of a future state thing than a current state. Currently, we don't have that capacity, but we have the means to get there. It's just going to take, quite a bit of coordination and some opportunities for improvement.
I do have a question about what beds you're referring to, because we do have, outside of hospital beds, we also have the step up, step down programs that are run by the peer support agencies. Our community mental health centers are all developing 6 beds within their communities. Are you going to have the ability to refer to those beds as well?
Well, I can't say where we'll get, but I can say that from a systems perspective, it makes sense to me that we would want to know about every possible resource that would be out there, particularly since one of our goals is to reduce or eliminate the need of, or the access to those higher levels of care. If there's a community resource, including a crisis bed, that could be used in lieu of a hospital bed, then certainly we would want to refer to that. So theoretically speaking, I would say, yes, we would want to have all of that information available to us.
Yeah, and I will just jump in here with my typical, I am a technology geek, and I think we can be doing so much more to connect the crisis system of care by utilizing technology and all that it has to offer. So I envision a time when our closed loop referral system includes multiple levels of service, whether that be sobering or detox or residential or inpatient and stabilization beds, so that utilizing technology, we can pretty quickly see what options there are for an individual who might be experiencing a crisis.
We do have to remember this is new for New Hampshire, so we're in our infancy with this.
Yes.
So there's a lot of growth that can occur, which is terrific to hear. A question from Catherine: will this service replace the CMHC mobile response teams? And I think you've answered this, but just to reiterate.
It's not replacing them. It is for those areas where rapid response already existed, those teams continue to operate. It's simply that they're operating in partnership with the access point now. So they're receiving their dispatches through the access point. And since those crisis numbers are all routed to us now, that's, so we're catching that. We're not losing those old access points for mobile crisis.
You are sort of the game in town now. You're the folks that we go through, sort of the gatekeepers.
For this service, we are.
Yeah, okay, great. Then we have some questions about CMHCs. Is permission from a caller to contact CMHCs going to be verbal and immediate? Sandra asks.
It sounds like that might be based on just communicating information back to the CMHCs. So yes, during the course of the call, we would ask about consent, right? Are you okay if we contact the CMHC? So in terms of, is that verbal? Yes. Is that response immediate? We are always putting workflows in place. So if you're asking, will we immediately hang up the phone and then call the CMHC? Not necessarily. We would provide that notification in cycles or over time, depending on the situation. If there was an immediate need, yes, we would hang up the phone and say, hey, we just got a call from so-and-so. We think it's important that you follow up.
That leads into Dana's question. How do you communicate with the CMHCs for referrals? Emails, calls? Do you wait for a response to ensure appropriate staffing for the referral?
Every way imaginable. So we have our closed loop referral system that provides real-time dispatch. We are often on the phone with them. And we are emailing at the end of the day and every morning, historic information, things like that. So at this point, we are pretty well connected with the CMHCs.
Jill did bring up, how do you find out about these things if you're not a client at a CMHC, a community mental health center? So NAMI New Hampshire is one of the ways. Eric, you were going to add?
Well, I was going to say that I think the state is, really putting a lot of effort into how they're going to market this in anticipation of 988. And so I do think that you're going to start to see a lot more perhaps television, print ads, maybe online ads, those kinds of things, really marketing the service as we get much closer to the advent of 988.
Ken Lewis brings up a really good point. He's at our peer support agency down in Nashua, the New Hampshire Mental Health Peer Alliance, and the other peer programs around the state can share in their communities like we're doing today. They have us live down at their center. They can do that on their social media and website. So that's a really important point. Thank you, Ken.
I would encourage everyone to share this information.
Some other questions I'm going to ping pong around a little bit. Sarah asks, can educators, school counselors call on behalf of students in crisis if we have parental consent?
Yes, I'm glad you bring up the question of if you have parental consent, because it's not quite so cut and dry, right? When you have a kid in crisis, if you can't reach the parent, but they still need intervention, I would encourage you to go ahead and call us and let us work that out. Even if the question of consent is not clear, I would rather us start that conversation and determine the best way to serve that child. But yes, certainly we would welcome calls from school personnel looking for help with their students.
Absolutely.
Carson has a similar question. Child being in crisis in school, if the staff has to make the call, would the parent have to be present for the clinician to conduct an assessment, or would consent over the phone be acceptable?
So I don't think the parent necessarily has to be present. I think there is a desire to have the parent contacted and perhaps on the way, right? I mean, whenever possible, we want to include the family in the crisis intervention. So I think there is definite, and I think this goes back to what Eric was mentioning, make the call, let's start talking through these situations so that we can coordinate services effectively. We do want consent. We do want parent involvement or guardian involvement whenever possible to be a part of that intervention. So let's talk through that together.
Great. Susan brings up a good point. Will there be a database of the people that have used the system? So if there are numerous calls, they can be tracked for follow-up care? Are they using the follow-up opportunities, and is the system working?
We are keeping records of every contact that we make. We do have a database where we make notes about what the contact was about, what interventions were provided, and we can go back and search, to track and trend progress for a particular person over a period of time.
And when appropriate, we would want to coordinate with their treatment provider in the community, right? So where relevant, we would want to get that person connected back to services to help resolve the crisis or improve engagement or whatever is necessary.
That leads into Peter's question. Is the provider contact limited to a community mental health center, or would you be communicating with private providers given permission and release?
With permission, we would be happy to share with any treating provider. I mean, that's just good coordination of care. That's a standard practice for any person in the mental health field. So.
Great. Are the records, medical notes of calls considered medical information? Will the patient be able to get these records to use or justify need for more services? Elizabeth asks.
Jeff, you might need to field this one. There is a process to request records, I know.
Yes. So yes, we maintain clinical records. Yes, those would be considered and effectively in a medical record. Those are protected as medical records, and you certainly could call in and request that information. The last piece of that, could those then be used to justify treatment? I can't remember exactly how you said that. Yes, these are medical records. You can use those to qualify for services as a part of a process. I don't know that process in its entirety, so I can't fully answer to that. But yes, you would have access to your records.
Ashley asked, in a state with a sadly very overwhelmed mental health system, how will the referral system assist with facilitating ongoing connection where many CMHCs have lengthy wait lists?
Part of the reason that this new crisis system exists is to provide a bit of a pressure release, right? So someone who is really struggling and in crisis might find that the crisis intervention that the Access Point or the rapid response can provide actually sustains them and actually de-escalates that crisis and gives them enough to make it until they're able to navigate the wait that is required to get into services. So the hope and the expectation is that this is really an intervention that is able to provide some relief and provide some comfort to folks while they're continuing to wait. I can't really speak directly to the capacity of the mental health centers. And I mean, I understand that New Hampshire is unfortunately not alone in the nation with having an overwhelmed mental health system. So this is something that's in place in a lot of the country. But in those states where there are these kinds of problems with lengthy delays, you do tend to find that mobile crisis is a very effective way of providing a means of intervention and support to people while they wait to establish care.
Daniel asks, if a person in a mental health crisis calls 911 out of lack of knowledge of 988 or just as an automatic response, will the 911 operators engage the rapid response team, or will 911 automatically trigger police EMS response?
At present, we are still negotiating with 988 for those transfer protocols, right? But in the advent of 988, when the summer comes along, that is a huge push nationwide for that coordination to occur. So that conversation is already occurring. We don't have concrete pathways right now for those transfers to happen, but the anticipation is that we will develop them, particularly as 988 nears for the summer.
And then as of now, we do have that coordination between the rapid response teams and law enforcement. So if law enforcement does respond to a scene and they feel like this isn't law enforcement specific, they can call into the access point and we can help get a team out there pretty quickly. So there is increased coordination already, and we're hoping that expands, threefold, tenfold as we move towards 988.
A couple of things about this number. This number that we gave today will continue even when 988 comes in July, correct?
Yes.
Right.
And Bernie brought up earlier, what if I have a cell phone number from Florida and I'm here in New Hampshire and I call? Now we're going to be dispatched to Florida, right?
Well, the dispatching process actually works off of the address that you provide us. Right.
Okay.
So we're not pinging your cell phone when you call us for your location. We're getting that information from you directly. That would be kind of a nice feature to be able to ping your cell phone, I guess, in some cases, but that's not the way that it works for us for right now. And also, as far as call routing, that's not an issue because you're calling that number directly and getting routed to our folks specifically. And once you give the location as New Hampshire, they'll understand that that's the service that you're seeking.
A great question. Do you have non-English speaking clinicians? From Suzanne.
We have been talking quite a bit actually about how to engage callers who are not English speakers. Jeff, I don't know if we employ non-English speakers, but I know we have access to translation and interpreting services.
Right.
So if we don't have a clinician or call taker available to speak the language of the caller, we have the ability to link to an interpreting service via phone or via relay if we're talking about someone who uses American Sign Language, so that we can communicate with that person with the assistance of the interpreter.
Yep.
Great. I did want to go to Nadine's question. It was Unite Us and Closed Loop Referral. Can you let us know about that? Is the intent to build upon the work that has already been done?
Yeah, we are looking on various ways how we can coordinate with Unite Us and other stakeholders, right? Doorways, 211. So we are working at how we can coordinate effectively. Officially, those are separate systems, right? So our closed loop referral system is not Unite Us, but we are looking at how we can connect and coordinate with them.
Great. Just once again, Susan, just to sort of loop back around, she says, I may have missed this, but who is actually on the response team if they are responding in person? Will police be notified for safety? So if you can briefly touch on that.
All teams include someone with clinical training as well as an additional support person, typically a peer specialist or some other person with specialized training to support de-escalation. In some cases, you might find that certain team members are responding virtually, but you do have a combination of clinical staff and paraprofessional or peer staff who are responding. The only time that a rapid response team would engage law enforcement is if there is a significant concern for safety, in which they might require the support of law enforcement to engage with someone safely.
Sharon asks, how do families or friends de-escalate a crisis while they're waiting for the team to arrive? That can be a rough waiting period if you're talking, 45 minutes or an hour?
It can be. And I don't want to overpromise for the call center. So Jeff, pull me back if I'm going a little far here, but the access point can remain on the phone with callers to continue to provide support, as long as that crisis is ongoing. So even if they're, if they are dispatching out a rapid response team, but they find that they still need to remain on the line, they can continue to provide some additional support. Of course, there does become a question at some point of whether rapid response is the best way to handle this, or if we need to look at other services. But that's something that we would handle on a case-by-case basis and figure out with the family what the best avenue is for support.
And honestly, to kind of further address that, when necessary, we of course would remain on the line until the rapid response team arrives, or until, should law enforcement be needed, law enforcement arrives. If family is present, and if during the course of the call we can identify coping skills, like, okay, it sounds like the rapid response team is about 45 minutes away. It sounds like you've agreed to kind of sit with your family and try and relax for a few minutes. I mean, if we can identify specific coping strategies or coping skills, or if we can put a plan in place that allows for it, we would then discontinue that call with the anticipation that the team will be there in 45 minutes. Every case is a little bit different. So again, I don't know that there's a clear answer, but we do have the capacity to stay on the line if needed.
Great. Lisa asked about the autism toolkit, its intended audience, and is it designed for times of crisis? Can you speak to that?
It's mentioned on one of the slides. So Jeff, I'm going to throw to you on this one. I'm sorry. I'm going to want to dive in too deep. Jeff is more familiar with call center operations. I'm more of the overall systems guy.
Yeah, apologies, not to get too far in. So in terms of the autism tool, I mean, this is where it would be a little more helpful to have somebody actually be able to ask the question and get some clarification. On the access point, we are utilizing a variety of risk assessment tools, coping strategies, de-escalation techniques. If someone who calls in identifies as having autism, we would of course look to how we can best support that individual in that crisis. So we do have some toolkits available, but I'm not sure specifically what we're trying to get at with this one. It's kind of a half answer, right?
Yeah, well, it's better than no answer. So we thank you for that. And Gretchen asks, are the crisis intervention stabilization therapists the ones who will be offering the stopgap immediate help employed by the CMHCs, the community mental health centers?
Yes.
Great. That's a quick and easy one.
Yes.
One of the questions was also about training fire and EMS. So first responders, are you planning on giving them some sort of training around what's going on with the system?
Part of my role is to be responsible for outreach to the community. And yes, training fire, EMS, as well as law enforcement in our local communities will be a part of our outreach efforts. Part of that collaboration that we're doing, the collaborative meetings, as well as some ongoing community training. So
I do want to come back down to the 911 call because I think there was some confusion over whether or not if someone calls 911 instead of the rapid response number, will the call be transferred to rapid response, or is 911 going to handle it just like they always have?
Again, I think currently I can't speak with confidence that it would be transferred to the rapid response access point. I don't think those protocols are clear enough to say that would happen consistently. Jeff mentioned there is some collaboration with boots on the ground. So the law enforcement officers on the ground who have responded may then initiate services through the access point, but that would be after they had already been dispatched. Again, though, as we build toward the future with 988, part of 988 planning is to develop those transfer protocols. So future state would include the intention that yes, those calls that come into 911 that are deemed appropriate to transfer would be transferred to the access point instead of being handled by 911. So future state, yes. Current state, I can't guarantee that will happen.
Correct. And every jurisdiction is a little bit different, right? So getting 911 and all law enforcement on the same page is going to take some time. I can offer that there are other areas, other states where this does happen, right? So once 911 is contacted and there's no apparent medical emergency or criminal intent for which law enforcement has to respond, then they can qualify that for a transfer over to a crisis line, behavioral health line. So we do see that occurring in other areas, and that is absolutely one of the things we'd be working towards.
Thank you. Nina did ask, I had talked earlier about peer support and Ken Lewis. What is his website and affiliation? So Ken Lewis is the executive director of Hearts Peer Support Center down in Nashua. So that's who he is for those who don't know. Plenty more questions here. I'm afraid we're not going to get to them all. How many mobile crisis teams are expected in the state and where are they anticipated to be located?
I can't say with confidence exactly how many teams, but I can tell you that all 10 community mental health centers are expected to have teams available and do have teams available. So that means that there is coverage for the entirety of the state. I can't say specifically exactly where each of them will be located because that will vary based on the geography and the size of the team for each region. But that would be a question if you're concerned about your local coverage, you would want to check with your local CMHC to inquire about what resources are available in your community.
The question came up about a character limit for chat or text messages. Any limitations that you know of?
I
am not certain, honestly. There may be.
And
Jeff, I don't know if you know that either.
Yeah, off the top of my head, I don't know. I mean, I think we are receiving texts and chats. I have not heard any concern about, we're only getting the first half of the text. So I am not aware of any concerns related to limitations. I'm sure there are, right? I'm sure there's a 500 character limit per text or something like that. But I'm not sure.
There's likely something in our disclosure statement on the website if you want to look. That would be where I would suggest that you look first to determine if that's already addressed in that disclosure statement.
And we're coming close to time. From Donna, do you have stats available and broken down from other states to show us your successes and where you may see possible gaps? I'm interested myself in New Hampshire with the launch about a month underway. Any issues you've identified?
Well, I do have a handful of numbers I can throw out quickly. We mentioned in the presentation that roughly in the neighborhood of 75+% of callers who call one of our crisis lines are able to be de-escalated simply by calling the crisis line. So essentially the support they receive by phone or text or chat is sufficient to de-escalate the crisis. And then of those people who do receive who other interventions, about 2% might involve 911 transfer. Around 5% of people might involve some sort of law enforcement contact. And then of the people who receive mobile crisis dispatches, we find that about 80% or so are resolved by staying in their home with existing resources. So we're talking about a smaller subset of a smaller subset who actually wind up having to be stabilized. For the first 24 days of the month, which is how long the service had operated, we had already received over 3,000 calls. We'd gotten about 41 text conversations. We'd had about 78 chat conversations. We dispatched mobile crisis almost 400 times, and we had set up about 122 of those crisis intervention appointments with the CMHCs for folks. So we're getting quite a bit of volume. Folks are using the service. We are successfully dispatching rapid response mobile teams. We're successfully linking folks to those crisis intervention appointments with their community mental health center. We're out there doing the work. To be candid, yes, we are identifying areas of improvement. Most of that has to do with just working out the kinks of communication between all the players in the system. But we are in constant communication, and we are identifying places where communication can improve, and we're putting things in place to improve that communication. We also understand that this whole system is a system in growth. And so the way that things look today are going to be very different from how they look in 6 months, in a year, or in 5 years. And so constantly we will be communicating and improving the system over time.
Terrific. Eric and Jeff, are you able to stay on for a couple more questions?
Absolutely.
Okay. There are folks who are looking for your contact information for follow-up questions, so we'll be sure that they get that. And we want to make sure that the Rapid Response Access Point team is familiar with Step Up, Step Down in the peer support centers, so they know how to make referrals. We want to
Okay.
make sure that happens. Michelle asked about law enforcement agreeable to going into the field for crisis calls around suicide. She says Virginia has had some barriers in collaborating with law enforcement and gaining support to ensure they assist in these calls. Have you had
Yeah,
experience with that?
Yeah, every state is a little bit different, right? We're in a time where the role of law enforcement is being questioned. And so there are some communities where law enforcement is hesitant to respond unless there is explicit criminal activity, right? And so in effect, that's part of the value of the service we're providing. We want to provide behavioral health support in community to resolve crisis as they occur. And we don't want it to default to law enforcement to have to respond. And then we think that there's additionally then that added value of when necessary, utilize less, but when necessary, we will be able to get law enforcement to respond. To date in New Hampshire, I think law enforcement has been very cooperative. I think we're building a very strong relationship, and law enforcement is generally pretty responsive in New Hampshire compared to some other states that I've worked in.
That's terrific. Really good to hear. Dana asks, are your call center employees held to any statistic metric goals as other call centers do outside of the mental health industry?
Well, I think, at the access point, we are looking to provide good service. There are different standards for service delivery in terms of we want to answer that call right away when the phone is ringing, right? So we try and answer, I think it's 90% of calls within 30 seconds. We also want to limit the number of hangups, the abandonment rate. So we want to keep the abandonment rate very low. Sorry. We don't want to see people waiting a long time and then hanging up the phone. So from those basic front door standards, we are always trying to improve our service and maintain a high level of excellence. And then we are always monitoring all of those statistics, including length of call, outcome of call, answer rate, abandonment rate, all of those things.
So 2 more questions. Can substance involved people who call the rapid response team or 988 eventually count on protection from criminal charges as a result of the intervention, or do criminal charges remain a barrier to folks reaching out for intervention? It's an important point.
We will not refer anyone to the legal system for substance abuse. That is not a part of our, a part of our protocols. So
great. One last question, given the growth in homelessness intertwined with mental health, how will you handle mental health crises triggered by unmet basic needs?
We do have relationships with 211 to help provide some of those additional resources that people may need. We're also in our workflows, there are some times when the workflow kind of loops over on itself because we recognize that there might be multiple needs that someone has. They may be in a mental health crisis, but they may also be having a housing crisis or a food crisis or all of the above. So we are sensitive to the fact that sometimes we might need to support someone in multiple ways. And we do have means of providing those, different methods of doing so.
Great. Kim Murdoch, our communications manager, did put in the Q&A regarding Nina's question about peer support. There's a website where you can find all of our state's peer support agencies. So we ask you to please take a look at that. And Kim also reminded us about the sharing of the Rapid Response Access Point materials. The flyer link to nh988.com is featured on NAMI New Hampshire's homepage, NAMINH.org, and in recent issues of our e-news. We've also seen thousands of folks engage with related social media on our platforms. And so we're glad to hear that others are also looking to spread the word. So thank you for that. I do just want to share screen as we close. Thank you so much, Eric and Jeff. Here is that phone number imprint. So you can take a picture of it with your phone. That might be helpful. Eric and Jeff are coming back to us. Because this service is new and we know there are going to be some lessons learned in the months to come, Eric and Jeff are going to be coming back to the NAMI New Hampshire Annual Conference. That will be on April 7th and 8th. They'll be joining us on the 8th. They'll be joined by Dennis Walker from Seacoast Mental Health Center, who's going to share the perspective of the mobile crisis team response, what it's looking like on their end. We're also going to have a panelist who's a community member who can talk about using the system and what it looked like from their perspective. So please stay tuned because more information will be coming. And once again, this will be recorded up on the onwardnh.org website on the education page. You'll also receive an email after this presentation, which includes a link to the website. It will have the survey link and you'll be automatically prompted to the survey after this. If you fill out that survey, which we do ask you to do, you'll also receive a certificate of attendance for today's event. And if you have any questions, reach out to me, mwagner@naminh.org. Thank you, Eric and Jeff. Until we see you next time, take care.
Thank you.
Thank you.